Thank you for joining us tonight. My name is Rene Prescora. I'm practicing academic pain medicine at the University of Florida, and I will be serving as the moderator for this webinar. I'm also very pleased to be joined by our other speakers. It's Dr. Jordan Newmark, who is practicing at the Stanford University, but also in private practice, and Dr. Thelma Wright, who is practicing at the University of Maryland, and Dr. Matthew Holland, who is practicing at the University of Virginia, and who has been practicing, I think, for more than 20 years before that in private practice. Some practical issues. We will go through the three presentations first. If you have any questions regarding the presentations, please use the Q&A icon at the bottom of your screen. Place your question there. At the end of all three presentations, we will review and discuss your questions live, or we'll answer them in writing. Again, please use the Q&A icon to place your questions, and we will make efforts to address them all at the end of all three presentations. Again, thank you very much for joining us. And we will start with Dr. Newmark talking about academics versus private practice. Again, thank you for joining us.
All right, perfect. Well, pleasure to meet everyone. Thank you for having me come to speak. Just a little bit about my background. I want to take a few moments to explain what my career journey has been like, just to set the context for the discussion about academic versus non-academic practice. So at the current state, I wear different hats. I'm an adjunct clinical associate professor at Stanford University, where I go several times a year for teaching, for a simulation research lab that I do, and see patients with the fellows and with the residents. I did my fellowship back in 2012 at Stanford, and I stayed on as a junior faculty member for about 5 years after I graduated my fellowship, and was the associate pain fellowship director, did a lot of educational work, academics, saw patients, also practiced anesthesia along with doing chronic pain management. And then in the year 2017, the opportunity presented itself to me where I was able to become chair of a department of anesthesia at a community hospital in the Bay Area, closer to where I lived. And so I had left Stanford as a full-time faculty member and was chair of a community anesthesia group with 60 people reporting to me. And I did that for 5 years. And so I got a lot of experience with leadership, but also with how community practice is structured and what that kind of work looks like. After 5 years of doing that, I pivoted my career again and went into the private practice world. So for a couple of years, I was working in a large anesthesia, primarily anesthesia-based private practice that serviced different hospitals around the Bay Area. And more recently, I'm doing private practice pain management with another private practice anesthesia group, still doing the adjunct associate professor work at Stanford, and I also do consulting. And so again, I've kind of done a lot of different types of practices in my career, and now I'm going to kind of describe the differences between all of those. So as you all get ready to graduate and start your early careers, you have more of a overview of what these different practices would look like for you and which one you would like to choose. So I have nothing to disclose. I'm not going to discuss off-label products or anything like this. So first, we're going to talk about academic practice. And I'm going to be using some terms regarding taxes. And at this point in your careers, you may not be worried much about taxes, but depending on where you end up living geographically and the cost of living in that area, tax issues actually become important as you're building your career and also building your family. So I might make some references to taxes. If you want me to give more clarity about that at the end, I'm happy to. But I imagine that Dr. Wright or some of the other faculty members here may touch on tax issues as well with contracting. All that being said, in academic practice, you're most likely going to be a W-2 employee of a university, and you'll start off as an instructor and work your way up the academic ranks to become a full professor. And so your activities surrounding academic practice are obviously patient care, but you'll also be spending a good amount of your time on direct patient care activities. So teaching, conducting research, traveling for meetings, collaborating with other academics at other institutions, becoming members of societies, joining national committees and probably regional committees as well to try to shape and lead the practice that you're a part of, whether that be in regional anesthesia, general anesthesia, chronic pain management. Academic practice is a big part of it is research and leadership and teaching. And so you can expect to be doing traveling and collaborating with others so you can carve out that niche. And also, as you get promoted through the ranks of an academic practice, those activities, those non-clinical activities become very important for your ascension up to become a full professor. Your reputation, your experience also becomes important during that timeline. So in terms of academic practice, you'll expect to see a very wide referral base in terms of the patients. Likely you'll see more complicated cases that perhaps community or private practice practitioners don't have the resources or the expertise to treat. Typically, the patient's insurance is less of an issue for you when they're in the academic practice. And you may find yourself in something called like more of a niche practice where perhaps you or your small group of team members are experts in something that's uncommon. So for example, at Stanford, we have like a headache division, which is part of the larger pain division. We have a group that works on buprenorphine. We actually have like an Ehlers-Danlos center that we sometimes collaborate with. So it becomes very highly focused on more rare conditions. And so if that's something that is of interest to you, becoming an expert in a less common condition, you'll probably find yourself in an academic practice. So I'm going to move on now to private practice. So in private practice, depending on the practice that you join, the tax structure can vary a lot. You might be a W-2, you might be something called a K-1 or a 1099, where you're more of like a business owner. So you can think of your private practice as being like owning a restaurant. So it's your third child. You have to worry a lot about cost containment, about your referral base, who are your patients and where are they coming from. You have to think a lot about if you're working with a hospital, what is the relationship like with your group to that hospital? If you're doing pain management, are you doing inpatient consults or are you using their hospital to do procedures? Are you admitting patients to that hospital for any reason? And what does the comp structure look like? Are you being paid to bring cases there? Are you being paid to cover their call for any reason? Or do you have to pay them for use of their facilities? So there's a lot of different structures that can be possible in a private practice. And so having an awareness of those details becomes really important if you're going to decide on a certain private practice to join. You could possibly see a very wide variety of different kinds of referrals, but they generally tend to be a little less complex than that of an academic center, just because an academic center probably has more resources, more people, maybe research activities, clinical trials surrounding certain conditions that a private practitioner simply just doesn't have the resources to handle. Also, when you're in private practice, the patient's insurance becomes a little more important because depending on what their insurance coverage is, that might dictate the kind of treatment that you're able to get authorized to have them do. Unfortunately, I hate to say it, but it is true that the insurance that they carry becomes more and more of an issue. And if there's a treatment that isn't covered by a particular patient's insurance, you have to take greater efforts into documenting, to talking to the insurance company and trying to get things approved for the patient. As you all likely know, there's been a lot of attention recently around kind of the good and the bad of insurance companies and how they conduct themselves and the challenges that brings. And I can tell you in my own private practice, I really do see and feel the challenges of insurance. Like as an example, I had a patient who in my chronic pain practice simply needed physical therapy, 12 sessions of physical therapy for back strain. And I had to do something called a prior authorization and a peer-to-peer phone call with another physician to get physical therapy approved. And so insurance sometimes can be stringent with what they approve of, and it kind of does suck the time of you as the patient's doctor to get that approved because you're not reimbursed for it. And so just something to be aware of. So getting back to the referral relationships, in private practice, it's very important to understand where your patients are coming from, who is sending you those patients, and what expectations do they have for the care of those patients. So for example, if an orthopedic, I'm going to use chronic pain as an example. If an orthopedic group is sending you patients for referral, you have to know like what they're expecting you to do. Do they want nerve blocks? Do they want you to prescribe opioids? Do they want you to recommend treatments and then they do the treatments that you recommended? So having that sense of the expectation is really important so you can work well with your referral base. Because if you get your referral base upset or you're not meeting expectations or there's a bad relationship there, you may find yourself with fewer patients and God forbid, your practice dries up, you don't have enough patients, you don't want to go out of business or not be able to feed your staff. So you'll find yourselves working a lot with your referral base and making sure that you're aligned with the kinds of patients you can take care of. You're meeting the expectations of them. And also you want to make sure you're attracting the right kind of patients. If a referral base is sending you patients that aren't a good match for your practice and your resources, it's going to frustrate everyone. So you'll be spending a good amount of time working on those relationships. And I personally love that. I think it's a lot of fun. But if you're not into that kind of thing, you may find private practice a little more challenging. Also in private practice, I found a lot of my colleagues do what I call extracurricular activities, like consulting, working with drug companies, doing medical legal work, doing other things that earn some extra income. And you can use that income to feed back into your practice to keep it going. So I call it feeding the beast. So understanding, how to feed the beast, how to keep your lights on, how to keep your staff happy, and, being creative with the way that the business is run, keeps you sustained longer. The last part of it is, especially as a new graduate like you all are, you want to understand the governance of the private practice. So is it a democratic group where every doctor in the group has equal say about decisions? Or is it seniority based and you kind of do what you're told by the practice owners? Is there a partnership model where perhaps you start off as more of a worker bee, and then once you become a partner, then you have a say in things? And then how does the compensation model work? Are you going to start off as salaried and then become a partial owner later? Are you given bonuses for productivity? So you want to understand how you're compensated and if that's going to change over time. And that becomes a lot more nuanced in general versus academic practice, where that tends to be more of a flat rate or a steady growth rate without concerns for the things that I just mentioned. But again, I'm making generalities. There's exceptions everywhere. So the next topic I'm going to discuss is, I'm a bit lumping this together, community practice, rural practice, safety net practice. So in those types of practices, you tend to be a W-2 employee, and you tend to work for a hospital or a group of hospitals that are affiliated with the local or state government of whatever geographic area that you're in. So you tend to focus on caring for the underserved, the underinsured. You're really doing the community a service by taking care of these patients that may not have another place to go. So the focus of a career in these types of environments is much more clinically based. You might do some degree of teaching. Perhaps you'll have some trainees rotate through, but you probably don't have your own residency. You might, but it's less likely. And your non-clinical activities, should you be given any, would likely be things like quality improvement activities, local communities, community outreach, perhaps like health fairs and things like this, to try to get to know your patient base better and give back to the community that's sending you patients. These types of practices tend to be more resource constrained, so you may not have all of the treatment options or devices or technology that you may otherwise have in an academic or a private practice setting. But it's still a lot of fun to practice in that environment. Again, I did that for 5 years when I was chair of a department, and I thought it was great. But you do have to understand there are some resource constraints sometimes. Generally, the insurance is Medicaid, Medicare, or the uninsured. And you'll often see, I won't say rare conditions, but you'll definitely see conditions that are very advanced beyond what would otherwise be like a well-maintained condition. So for example, you could expect to see very advanced diabetes. You may see untreated gangrene that wasn't treated readily. Now the limb is very injured. You may see terrible things like someone is amputated and they have really bad phantom limb syndrome because they didn't get adequate analgesia at the time of the amputation or shortly thereafter. So the insurance and the building of relationships becomes less important in community practice. So you don't have to worry about that so much. The patients just generally show up and you take care of them. So those relationship buildings and those insurance issues tend to be less of a focus when you're in these environments. So the last thing I'm going to talk about, and this does get a little confusing for people, is locums and per diem practice. And so those are different things, and sometimes they're lumped together, but they're technically different. So per diem, that literally means as needed. So if you're going to work as a per diem physician somewhere, your availability largely dictates when you're going to work. So you make your own schedule, you provide that schedule to the practices that are hiring you on. You tend to be a 1099 contractor, not a W-2 employee from a tax perspective. As a per diem, you'll usually just get paid directly by the organization for the work that you put in. You generally don't have to worry very much about referral relationships, scholarly activity, research, the patient's insurance. Those things are generally handled by the greater group that you're coming into. You're really paid for just showing up, taking good care of patients, being available, and getting paid for that work. And so you'll have a very high focus on your own availability, your own schedule, and making sure you're just taking good care of patients. As the group grows that you're a per diem clinician with, you can certainly ask about like part-time partnership opportunities, part-time ownership opportunities, but more likely that wouldn't be offered to you because you're just coming in to cover for other people when they're out. But you can certainly ask. So locums versus per diem. Locums tends to be, again, you're doing per diem work in that you're working as needed on a part-time basis for whatever group or organization needs you. But locums tends to have a third-party vendor, like a company, that manages aspects of your schedule, manages aspects of your billing. They may reimburse you for travel if you're traveling far away. They'll help you with a lot of onboarding and malpractice insurance kinds of things. So literally the company will just send you where you need to go, handle a lot of the issues surrounding that practice, and you get paid and you're done. Where in a per diem situation, you're doing all of those other activities on your own. You'll need to find your own malpractice, make your own schedule, do your own billing, and make sure you're getting paid for the work that you do. So you don't have that extra layer of management that's helping you when you're with a locums company. Now, but be aware though that the locums company, whatever they're paying you, they're getting paid even more by the greater organization because they're getting paid for helping to manage you. So just be aware of that fact. So what I often see happens is people start with locums, but then they, after some years experience, say, you know what, I don't really need the locums company to do all these things for me. I can do it for myself. Then they switch to per diem, do it on their own, and then they get paid a little bit more in their pocket because they don't need the company to do those activities for them. So that's pretty much it. I'm just here to, again, give you a very general broad strokes overview of different consulting environments, and I'm here to answer any questions you may have about those different environments. Thank you for your time.
Thank you very much for the outstanding presentation. And like for our audience, please use the Q&A button function at the bottom of your screen to place any questions. And I think we'll be moving to Dr. Wright. She will talk about employment contract review.
Good evening, everybody. My name is Thelma Wright, and I've actually been in academics for, since 2006. And I actually got here thinking I was going to do 2 years in academics because, a 1 year of Payne Fellowship I thought wasn't enough. So I was going to do 2 years, learn from the best, and then move on to private practice. But it didn't work out that way. I've been here since that time and ended up being program director and medical director and so on and so forth. So I will be talking about employment contract review. So sort of you've finished your fellowship and you're looking for a new job and you have a couple of offers. What do you do with these offers? I have nothing to disclose, no disclosure. I will not be presenting any off-label product use today. And today what I'm going to do is, talk about some of the contracts that, what pertains in a contract when you get them. And basically the contract of your first job would, shape your future, your professional future. We'll talk a little bit about compensation models, some covenants like non-competes, termination clauses, and so on and so forth. Let me move. All right. So you get a contract And also, let me mention that, the residents and fellows here at University of Maryland, when they do get a contract, I get all the calls. And Dr. Wright, can you look at my contract because I have the JD. So I do look at your contract, and certain things you may not see, but I will see because I've looked at a few of them. So I can read between the lines and, draw your attention to those things. So if you ever needed your contract reviewed, I'm happy to look at them. So you definitely want to know what the job is about, job description, whether there are some defined roles and responsibilities. You want to know what your duties are. What are you expected to do? And I'm going to assume most of you here are pain fellows or, residents interested in pain. So are you going to be doing mostly procedures? Are you going to be doing mostly clinic? Will it be a mix? Will you be going to other facilities? Is there going to be compensation for driving to the other facilities? What will be your call schedule? Are you going to be in-house call versus take-home call? Do you need to live close to the hospital? So this would apply to anesthesia jobs also, not necessarily pain medicine, because you want to know, do I have to be in-house or do I have to live 20 minutes away from the hospital? Or how soon do they expect you to be in the hospital when you get called? How long is your initial contract? Is it a year? Is it 2 years? And is it automatically renewed? Or can you sit down and discuss some of the content of your contract? Are you able to get more money, or is it already been outlined in the initial contract? So if I'm going to just pick a number, let's say you're making 500K in the first year, is it going to go up by 10%? Are you going to make a base, or are you going to make a base with a bonus? And what is the bonus contingent on? Is it productivity or patient satisfaction scores? Where I am here in our academic center, our bonuses are based on research, given talks, teaching, Press Ganey scores. It's a whole algorithm on how we make a bonus. It's not just productivity. But in private practice, you may be making bonuses based on RVU. So I noticed a lot of the new graduates, when they get out there, they're working hard, and not taking vacation because they want to make money. And then as they get older, they've been in the business, they start to slow down. So, I mean, you have to pay your loans. You may get lucky, you may get a practice that would pay for your loans, or you can add it to the contract. I usually tell my fellows, if you don't ask, you're not going to get. I tell my kids the same thing. Ask, you never know. So just ask for the world, and maybe they'll meet you in the middle. So if you want some of your loans paid for, ask for it. If you want, whatever, just ask for it. And the worst they can say is no. Are they also going to be looking at how quick you sign your charts? Over here, we have a 48-hour turnaround on charts. Are they going to look at that? Is that going to be a benchmark for your bonuses? So you have to ask all those questions. And of course, I already mentioned the fact that there are some practices that would have other facility locations, and you want to know, are you going to be paid to go to these locations, or is it expected of you? Or can you just stick to one location? You also want to know the reporting structure. Who is the decision maker? Is it the group that makes the decision, or is there a chair, one person who makes the decision? You also want to know that. All right. So what are some of the compensation models? There are some practices, that you get a base salary maybe the first 2 years. I remember when I knew I wanted to go into academics, so I think I only looked at a couple of private practices. And I remember going into one, and they wanted me to start a new pain program. They never had pain. And I was straight out of fellowship. I was a bit nervous. And so they said, we'll pay you for 2 years, if you're concerned about that. And then after that, we'll see how much you made, or, what your collections were. And then we'll decide whether to go on sort of a fee for service basis. Obviously, I didn't take that job. So you could potentially take a position that would guarantee you a salary for the first 2 years. However, the downside of doing that is if you're working hard and you're making so much for them, then you don't get to see that. So you could do probably half and half, where you can get a little bit of a base, and then the rest of it could be based on productivity. Benefits package is important. You need to write down what's important to me. Right now, what's important to me is time off, vacation time, non-clinical time. So you need to know what's important. Do you want them to pay for your CME? How much CME do you expect, or how many meetings do you want to go to? Retirement plans, are they going to be giving you a good package when it comes to retirement, your health insurance, dental insurance, all that. You want to know that. And then, loan forgiveness. And I think that's a big one, especially if you're going to a less desirable area. I would ask for that. If you're going to, a place where there's not really a lot of life there, you're asking for everything. Can you pay my loan? Maybe over 3 years. I had a fellow who didn't even think about it. And I said, oh my God, you're going to Timbuktu and you're not going to ask for that? You better ask for that. And they did. I think they gave her 50,000 a year for 3 years. So you have to make sure you're willing to stay in that location for 3 years, because if you don't stay, they're going to take their money back. And you also want to ask about productivity. They may say, oh, 25% of whatever you make. Always ask for more. You can always ask for more. And like I said, the worst they can do is say no. All right. Now, what about, restrictive covenants? You don't really see, at least here at University of Maryland, we used to have a 2-year, I believe it was 7-mile radius, but I think that's really gone because of COVID. A lot of people have retired. A lot of people, so we are so short of staff that you're not going to insist on these covenants, because people are going to leave and people are getting offered so much that these covenants have sort of become very soft. We still have it, but I don't know that they're enforceable. So if you go to a place like New York City, your restrictive covenant could be a few blocks, because New York City is quite small, versus here in Maryland or in in the country somewhere, it could be a bigger mile radius. So you want to look into that, especially if you work in Baltimore and you go to a practice like one of these big practices that have a practice everywhere. If you have a 5 to 12-mile radius, you pretty much have to go out of Baltimore or go out of the state, because that particular practice has practices everywhere and you can't be anywhere close to the different practices. So you want to know what you're signing yourself for. You would also want to know buyout options in case you decided to leave earlier than your contract. Is it worth negotiating? Can you buy out and leave, or can the new practice that's getting you, what's stealing you from the old practice, pay you and pay for you to come out? I remember, a few years ago, a few of our surgeons moved to Hopkins, and I think Hopkins may have had to pay to get those surgeons, because those surgeons had the restrictive non-competes, and so they had to buy themselves. I mean, Hopkins had to buy them out of there. Always, you want to know how long is your initial contract. I don't know that I would advise anyone to sign a very long initial contract, because you may hate it. You may go and hate it and decide you want to leave. So if you go signing a 3-year contract, that may not be beneficial to you. Now, in the pain practice, especially if you're in private practice, when you're leaving, they may have you sign an agreement that says you cannot contact any of your former patients. I mean, if the former patients finds you, then of course they can come to you, but you can't contact them and say, hey, I'm going to so and so practice. You can come there. You're not allowed to. So, but however, if they find you, then. Now, one exception would be maybe family members who come to the pain clinic, or your friends who come to the pain clinic. That could be an exception. All right. What about termination clause? There have been occasions where, people will start and they absolutely hate it, or what was presented to them wasn't really what they went to see. So I'll give you an example. I had a fellow who went into a practice, and, obviously we get a little bit of buffering when you're an academic. You don't have to, prescribe a whole lot of opioids when you're in academic practice. And then you go into private practice and you pretty much have to make your referring physicians happy. So you tend to prescribe a little bit more than you normally prescribe as a fellow. So they get there and, they ask, how, do you prescribe opioids, or how much opioids? And say, oh, no, we don't do that much. We really don't. We just, very small amounts of opioids. We do a lot more procedures. And of course they get there and it was totally opposite. They were prescribing on the first visit. We don't. We have to get a urine screen. We have to send the patient to pain psych. But that does not happen in the real world. In private practice, you can't do that. You can ask Jordan there. You cannot do that. You can't, check everybody's urine and wait for the urine results and take them to pain psych. You just can't do that in private practice. So obviously the fellow was not very happy and wanted to leave, because they weren't used to prescribing high doses and first visit, and it was hard for them to break free because they had already signed. So you want to know how can you terminate, and for what reason? And usually when you have to give notice to terminate, it's anywhere around 60 to 90 days. I know if I ever had to leave here, I think I may have to give 6 months because I've been here for 19 years. So I have to give them a bit of notice. But if you just got there, I think you can get to a point where you don't have to give that much notice. Now you can also be terminated for cause, like you have license cause or some criminal activity, or a patient complains about some egregious activity that you did. So those things you may be told to leave immediately. I remember we had a nurse who, I think someone smelled alcohol on them or something, and they tested her immediately, and it tested positive for high amounts of alcohol, and she was frog matched out of the hospital. So those are the things that would make them terminate you with no cause. Now, there are occasions where you may do something that's fixable, and so you can sit with the decision maker to see whether you can get a probation period where they can actually observe you. And we've done that to for some of our physicians, where there's been a report or there's been some issue, and then we have had them have a mentor and they get observed for 6 months or so. If that happens, if they terminate you, you also want to make sure in the contract that there's a way of getting paid either for a month or 2 months or whatever have you. You want to have that in that contract if they would agree to that. Some of these contracts are pretty solid. They wouldn't change it, especially if you're going to an academic center. I remember when I started at University of Maryland, they told me before I left, we don't change anything on our contract. So academics is a bit different. Maybe now with the way the market is, you may get a little bit of leeway with the money they will pay you, but there's certain terms in the contract that they will not change, no matter who you are. Now, tail insurance. So what is tail insurance? So tail insurance is the insurance that you can get, or the institution or the practice can pay, so that if you get sued after you leave, you can still get covered by the insurance. So most of the time they have occurrence-based or they have claim-based, which is claims-based is if it happened during your tenure when you had insurance, it would be covered. And occurrence-based is when it happens during the policy period, it would get covered. Now, tail at least helps you when the patient sues you way after that insurance has ended, or way after you've left, you still get coverage over that incident. So you want to ask about tail insurance, and if they won't pay for the whole thing, at least you can probably work on getting them to pay for half. I personally would ask for them to pay for all of it, not half. Another thing I should mention, you also want to know what exactly do they expect of you before you leave. You don't want a situation where you leave and you have notes that you didn't sign. So most institutions would ask you to sign all your notes, make sure you're up to date before you leave, because they have to be able to bill them. They can't go and make up some notes for a patient that you saw. We actually had a nurse practitioner who worked for 6 months for one of our nurse practitioners who went away on sick leave, and he had so many notes he didn't complete. So we had to get him to come in, finish them before we could really release his last paycheck. All right, so we talked about this, claims-based and occurrence. I've already explained that. So claims-based or claims made covers only when the policy is active, and occurrence occurs when the incident occurs during the policy period. Tail coverage will differ from institution to institution. I would advise you try to get them to pay for the whole thing. Coverage limits always may vary. And you also want to ask about what some of your policy limits are when it comes to defense. Now, if it was a criminal act or it was an issue that they would not cover, or like license issues, they may not cover that. And I don't think a lot of institutions would agree to cover that. All right. So what are some of the negotiation strategies? You pretty much have to you want to know what the going rate is. in that area. You want to go, with your information. You want to be equipped with how much people are making in that area, what the benchmark is for the specialty. You want to know that. It wouldn't be very smart not to know. And then you also want to write down, what are your non-negotiables? I know, I mean, I've been in this job for 19 years, so I pretty much know if I had to leave, there are certain things I would not, I would not compromise with, like with my vacation time, with, conference time. I would definitely want moving costs. They have to pay for me to move. So those are the kind of things you want to make sure you write down. What do you want to see? Do you want 6 week vacation versus 8 week vacation? Do you want a academic day? Do you want to have procedures 2 days a week? Do you want to work in one practice versus going to 6 different practices? So write it down and make sure that you speak to them about it. And then even if you want to ask for modifications, make sure you don't sound, especially if you're just graduating, you can't go as a new graduate and start throwing your weight around because you're a new graduate. So you just want to make sure that any modification that you are offering will come up like a mutual benefit, right? So it's like, okay, even though it's going to benefit you, it's going to benefit them. So even if you're asking for 10 weeks of vacation, you could say, you know what, I can work 10 hours a day versus the 8 hours a day. So they're getting something for giving you whatever you're asking for. So always make sure you don't come across as this cocky new graduate, I'm the best and you have to give me what I want. You will always want to be humble, be respectful, but still try to ask for what you want. And seek professional review. Some people think the contracts are so standard. They want to, they want to save a couple of thousand. Just get someone to look at it. I can't tell you, I usually do it for my fellows for free because we're in the procedure room. Like, Dr. Wright, can you look at this real quick? And obviously, they're getting my time for free. And I'll look at it because, they're my fellows. But, show it to somebody. You can show it to an attending who's been doing it, but definitely get an attorney. There's some attorneys who would say, you know what, I'm not going to charge you now, but when you get your first paycheck, this is how much I expect from you. I can do that if you needed to use me, but just make sure someone looks at it. Now, if it's an academic institution, like I said, they normally wouldn't change much. So you may get away with not giving it to anyone to take a look at it. But not private practice, because I tell you, they can put some clauses in there and from your, untrained eye, you may miss it. All right, so read every word. Read every word, underline. If you don't understand, look it up, call somebody. Just make sure you don't sign something you're not sure about. So read every line, ask for clarification. Even if you think you're going to sound stupid, just ask. Just ask. It doesn't hurt. After all, you may not even end up there, so who cares? Just ask them. And then compare. Compare offers. Don't just look at one job and say, you know what? I mean, you could. I had fellows who, before they even started their fellowship, they knew where they were going. They knew they were going to this practice. One guy came to me. He wanted to just learn how to do spinal cord stimulators so he could go to the practice and be the spinal cord stimulator guy. So he knew where he was going. So it was a no-brainer for him. He didn't, he already knew that was the place and that was it. Versus if you're not sure, get multiple offers, compare them, and decide what works best for you. Like I said, consult with a healthcare attorney, always consult with a financial advisor, so they can actually help you grow your money. It's always about growing your money. And if they say something, if they say something and they don't write it down, don't believe it. Let them write it down because they will, you meet with them, they wine and dine you, they can say whatever they want to say. I never take that. If they don't write it down, they didn't say it. So if they say, when you come, I will give you an example. I got this job, I literally had dinner. I hadn't even done the interviews yet. And I had dinner and the guy offered it to me on the spot. It was an academic center. I had just gotten the associate professor role like maybe 2 weeks prior. And so when I get there, I said, I just got associate, so I really want associate. And he said, no, when you come, we'll give it to you. Don't worry. Don't worry. We'll help you get it. I didn't take the job because I don't believe it. If they verbalize it and they don't write it down, it didn't say it. So just make sure that whatever they say, they write it down. And even with this associate professor, we'll make sure you get it. Even if they write it down, I don't know if it would have to say in 2 months, we will confer the associate professor position to you. That maybe I would go for. But if they say we will help you, that's not a given, because other, some institutions, they're, getting to associate professor may be a bit difficult. So you want to always make sure that if they promise you, it's written. Just make sure it's written. And that's it. These are my references. If you need to contact me, I'm right there. You will find me on the internet. Thank you so much.
Well, thank you very much. And I see we also have some questions we can discuss at the end of our third presentation. And this will be given by Matthew Holland. Matthew, thank you for joining us tonight.
Thanks for having me on the show. I'm going to share my screen here. All right. My name is Matt Holland. I am at the University of Virginia in Charlottesville. I have a little bit different background than because I did it backwards. I was in private practice for the last 20 plus years, and now I am at an academic institution as of about 6 months ago. So you are either going to be subjected to some really interesting information in the next 20 minutes, or you're going to get a summary of all of my life's bad decisions. I'll let you decide. I don't have any disclosures. So we're going to do this as a series of chapters here. So chapter 1, being unhappy is expensive. And I really mean this. I think being happy is a skill. I think that many of us in residency have this thought that, residency and fellowship, that just as soon as this onerous task of being a trainee is done, that everything's going to be perfect and it's going to be and that medicine is going to be this fulfilling career. And if only you had all of these, these problems with the call schedule and your other residents and being a trainee, that life would just be perfect. And unfortunately, I don't think that's really true. I think you really need to make a decision as you look at yourself and as you look at jobs and decide what it is that makes you happy in life. And doctors are not a homogenous group, and particularly in private practices, there are groups that are more focused on some things than others. And I've certainly seen practices that are very focused on income, and I've seen other practices that are much more focused on having time off and time with family. And I think, both are fine, but recognize what you're getting into and make sure that you are entering into a practice where the other docs, whether it's an academic practice or whether it's a private practice, that you're entering into a group that's got a similar idea of what they want out of a practice, because you're much more likely to be a good fit. And then I think, again, sort of what makes you happy. If one of the things that you recognize that makes you happy is possessions, and I'm not saying that to be mean or to pick on anybody, but there are people who are, it's very important to them that they have a big house, that they have a boat, and that's fine. But I mean, really look in the mirror and decide if that's what's important to you. Then yes, a practice that's oriented towards money may be a better option for you. I will give you a piece of advice that my grandfather gave me, which is what he called the 3 F's rule, which is that if it floats, flies, or fornicates it, I don't want to own it. That's a rental item. So horses, airplanes, and boats are on that list. Chapter 2, how to plan for the unexpected. This is a pretty simple one. Live below your means. And I really think, medicine is just, it remains a great career. I don't know many lawyers or business people who are, mid-50s who are really excited about their career still. And I think that's one of the great things that's unique about medicine, is that there's always room for professional growth for us, and it's always intellectually stimulating. And even in private practice, where I was doing just procedure after procedure during the day, every procedure was a little different. Every patient encounter was a little different. And I honestly was never bored. But while medicine is one of the most intellectually rewarding, it's also an interesting profession because you work harder and harder every year as your practice grows. And that's particularly true in pain medicine. And unfortunately with that, the reality that I've seen is every year you work harder and harder and you see more and more patients, but you make less per patient, and that's sometimes a tough pill to swallow. So if the money from medicine is the only thing that makes you happy, that can lead to some frustration in your career. Medicine's a career about deferred gratification. When you're a med student, it's wait till you're a resident, it's going to be so much better. When you're a resident, it's wait till fellowship, it's going to be better. When you're a fellow, it's wait till you're an attending, then wait till you're a partner. And I think as doctors, we sort of get used to this idea that it's going to be better next year, that the next step is going to be what's different. And the reality is you finally get to become an attending and you're making some money. But then all of a sudden it seems like your expenses go up quite a bit. Your loan repayments begin. You may have children, your taxes certainly go up. And then it's sort of this question of, wait, why don't I have a whole lot more money than when I did as a resident? So there are some things that we have control over. And for me, one of the most outward manifestations of our income is what we drive. And that sounds like a silly point, but my gosh, I mean, many cars are well in the six-figure range these days. I mean, certainly the average selling price for a new car last year was $48,000, which is just astonishing to me. I will tell you, as a pain doc, depending on the practice you're in, my practice, my primary referral base was primary care doctors, and I'm married to a pediatrician. I had a fair amount of social interaction, and I live in a small town. So the primary care saw me. They know what you drive, and they don't celebrate your brand new $150,000 car that they see you driving. I can tell you that I have a not terribly expensive pickup truck. And I think when the primary care see me in that, they assume that I'm a little hungry and that means I'm always happy to see another referral or see a patient after hours because I need the money. And I'm okay with that. I could do better than that pickup truck, but I think it kind of works when you're trying to keep it low key, because I think the assumption is that doctors are rich. And as you'll find out soon in practice, we're not all rich and we have a lot of expenses, and maintaining a practice is expensive and it's hard work. I'll tell you that patients seem to always know what you drive. I don't know how they figure it out, but they all know what you drive. And again, I think they look at you suspiciously when they get their EOB and they see how much you charge for your procedures, and then they see what you drive. And if they see you driving a not very noticeable car, they just don't think about it that way. I will tell you for sure, your staff knows what you drive. And if you don't raise their salary every year, they look out the window and see your expensive car outside in the parking lot and think, well, he's taking it from me. So I do think if you're not a car person, keep it low key and fly under the radar with that one. You will be amazed that your spending will miraculously rise to meet your income when you finish residency and fellowship. So make sure that if you've got a spouse, that you're on the same page about spending habits. It's a common source of marital discord. And so it's a good conversation to have before you have any income, to sort of think about how you're going to manage that and where that money's going to go. And I'd recommend paying off your debts, and in particular your student loans, as quickly as you can. Unfortunately, the reality for medicine is your salary may go up if you make partnership or as you get promoted in an academic center, but reimbursement just seems to go down every year and expenses go up, and it's a frustrating trend. But I think you would do well if you can keep your spending in check to pay off your debts and make your goal 5-6 years after you finish fellowship to try and pay off all of your med school debt. So talking about controlling your expenditures, having some control over your personal overhead will give you a lot of freedom in the future. And I was part of a private practice in the early 2000s that went through sort of a bad breakup, where half the group was trying to leave and take all of the high-paying business with them, and leave the older guys in the group with the low-paying Medicare and Medicaid mix in the hospital. And what stopped it was that a bunch of the younger guys in the practice had so much personal overhead that they realized when they started their own practice that they could potentially have 3 to 6 months of little to no income. And they went, oh my gosh, I can't afford to do that. So, again, having control of your personal overhead and having some savings in the bank really gives you a lot of freedom if you do need to make an unexpected change. And it's hard. I recognize, I was with one of our fellows yesterday, was looking at housing prices outside of Nashville. And I mean, it's shocking to me how expensive cars and houses are right now. But I mean, I think a question to ask, and not one person on this call can answer this, is, will your first job be your forever job? And I think, we all put a lot of thought and a lot of planning into our first job after residency and after fellowship. And statistically, maybe it will be your job. Maybe you'll find that perfect job. But the reality is that jobs change over time, and also you'll change, and your jobs and your needs may change over time, and it may no longer be the right match for that job. And moving from one city to another, and in particular moving jobs, is expensive. So save early and make sure that you have some money in the bank to give yourself that freedom. And, while you're trying to pay off loans, you're also trying to build a nest egg so that you can take advantage of 30 to 40 years of compounding before you're ready to retire. So if we look at some stats about will your first job be your forever job, I wish I could tell you that everybody's going to find the right job and they're going to stay there for the rest of their career. That doesn't seem to be the trend in medicine right now. And I think that's multifactorial. I think that the generation that is finishing residency now has more of a focus on lifestyle than my generation did. And I think that's great. I think that as medicine becomes more corporate and maybe somewhat less satisfying on a day-to-day basis, people are recognizing that they need to have things outside of medicine that make them happy. And I think that's great. But with that also comes some frustrations when they find a job that doesn't support that lifestyle. And there have been a number of studies showing that more recent grads are more likely to leave their jobs. So what can you do about that? Take advantage of it. You may find that works for you, and you may find that there are greener pastures other places. And I think be willing to pick up and leave, but things that you can do to make that not be a huge financial hit may include renting for a year or two until you're sure that you're in the right practice. And everybody that's finishing residency and fellowship has this sense that they've just got to find their perfect house. And I tell you, having sold houses, there's nothing I enjoy more than selling a house to an out-of-town buyer who has no clue what's going on where I am. But if you don't have to, I'd rent for 6 months to a year, even though it's a pain in the butt, but to make a second move. But local moves aren't that expensive, and it just gives you so much freedom. And as you get to know the place that you're moving to, you'll learn a lot about it, and you may decide that maybe the part of town you found initially isn't actually where you want to be. So there are a number of other costs that come with changing practices. Dr. Wright mentioned a couple of these. But remember also, if you do change practices, you're going to lose income during that transition. You may go from being a partner in a practice back to a base salary, or in my case, you may go back to being a lowly assistant professor after you were a partner. And the other thing is tail coverage. Tail coverage is typically about 1.5 times your annual premium. There are options when you start. One of the other options that we didn't mention earlier is something called a nose-in policy. Your malpractice insurance is less expensive when you start practicing. You're not as busy. You don't have as many covered lives and events that you're already covering. So for the first 3 years or so, your policy is cheaper. There are policies called nose-in policies where you pay the mature premium rate from the get-go. And that essentially is a pre-purchase of tail coverage. And so if you have to purchase tail, you might be able to negotiate a nose-in policy whereby your employer simply pays for tail from the get-go. And then other costs with moving, obviously real estate commissions are significant. Even though there was some legislation about that, you still have to pay real estate commissions. It just kind of changed how they do it. And then also the legal expenses, particularly if you're going to negotiate out of a non-compete clause. There was some discussion earlier about the enforceability of non-compete clauses. I will tell you that particularly these large equity capital practices will absolutely spend as much as it takes to enforce non-compete clauses, because if they let somebody out of that non-compete, they are then giving license to all of their other doctors to leave. And there's a lot of unhappy doctors in some of these practices. Non-competes, there are some limitations to them. There may be some things that you can do, but it goes back to what Dr. Wright said about getting an attorney. And I would not only get an attorney to review your contract, I would get an attorney who's in the state you're going to, who specializes in medical contracts. I live in a town of about 100,000. There's one guy here, that's all he does, and he's pretty busy. I think most cities are going to have somebody who's pretty knowledgeable about that. And you don't have to physically see him. You can have a Zoom meeting. They'll charge you a couple $100 an hour and go through your contract. The other thing that you might want to find out is whether your state is what's called a blue line state. What a blue line state means is that if you have one line in your contract that is not enforceable. So for example, you are an anesthesiologist who did a pain fellowship, you went to a predominantly physical medicine and rehab group, and your contract said that you are not allowed to practice physical medicine, rehabilitation, and pain medicine, that would be not enforceable since that's not your specialty, which means your entire contract is essentially null and void from a non-compete enforceability standpoint. So again, that's something you would really want to know before you sign that contract. And if you thought maybe there was a chance you were leaving and you found that in there, you might not want to tell your employer about that. You might want to just sign the contract and let them eat that mistake, a year, 10 years, 20 years down the road if you decided to leave. So it's good information to have, and it's worth a couple $1,000s to have an employment attorney review that stuff with you. Willie Nelson said, why is divorce so expensive? Because it's worth it. It's expensive to leave a medical practice. Sometimes it's the right answer. And again, your happiness is the long-term goal. But hopefully you don't have to ever do it. All right, chapter 3, we're going to talk briefly about protecting what you have. It's not hard as a fellow because most of you don't have any assets right now, but we want to think about what to do as you gain assets in your life and as you save money. One thing that you can do is form a trust. It's another thing that's going to cost you a couple $1,000s. You don't need to do it your first week out of residency. But if you form a trust, you no longer have assets in your name. You can find attorneys in every city and town who specializes in wills and trust. You form a trust in a name, whatever name you want. You put all of your assets in the trust. It may vary from state to state, but for example, your house could go in the trust. All of your bank accounts would go in the trust. Most places you don't need to put your retirement accounts in the trust since they're protected from litigation. It's also a real pain in the butt to change the name on your retirement accounts. But you don't put anything in that trust that could be a liability for you. So for example, cars, vehicles, if you get in a car accident, you don't want them. My crappy Toyota pickup truck is owned by Matt Holland, MD. If I get in an accident, the only thing I own is another crappy car. I don't have anything else in my name. Everything else is in the name of the trust. I'm just a trustee. The trust isn't me. So things like cars, the other things, you wouldn't want to put your student loan debt in the trust. Because again, if something happened to you, then the holder of that debt could go after the trust to try and get the money. So you leave that in your name. And then if you have another business, so for example, I have a medical consulting business on the side, that's owned by me personally, because if I get sued, I don't want them to have access to the trust. This is hopefully a long way down the road for everybody on this call, but the other thing that's nice about a trust is you don't have to go through probate court. So if you die, everything's owned by the trust. You make your kids the trustees, or a trusted family member or friend. And then the other thing is you can't hide your assets in a trust if you're in the middle of a lawsuit. So do it early in your career, maybe not the first week, but it's probably something worth doing when your kids are young and you're thinking about that stuff. Because if you have ongoing litigation, they will have looked at your assets early on. And then if you try and put them in a trust, they'll say, no, that was there when the suit was filed. Other quick note on protecting your assets, disability insurance. Some employers will offer disability insurance. Make sure that it is not only occupation specific, but specialty specific. You don't want to have a hand injury, not be able to practice as a pain doc, and then be told, well, you could go back and retrain and do family medicine, so we're not going to pay you. The other thing is your employer may provide disability insurance, but you want to have your own policy, because if you pay for that policy in post-tax dollars, then any benefits that you receive through that policy are not taxable. If you have a disability insurance policy through your employer, any benefits that you're paid after being disabled are taxed. And then one other thing, and this is a cheap one, and it's easy, and once you get out, you ought to just do it through your car insurance manufacturer, whoever provides your car insurance or your home insurance. Get an umbrella policy. I have $1 million umbrella policy. It just covers you from stupid stuff like somebody, you're out walking your dog, and your dog knocks somebody over, which happened to my wife. That's the kind of thing an umbrella policy would cover, because we got sued for that. It was fortunately we were med students, so we didn't have a lot of assets, but that's the kind of thing you want to be protected from. All right, so here's your review of your new attending to-do list. So try and live maybe a little bit better, but closer to residency standards for just a little while longer, and pay off that debt and save some money. And start saving now so you can take advantage of compounding and build a cash reserve. It is just absolutely amazing how the difference in how much money you'll have if you save it for 30 years versus 20 years with compounded interest. Control your expenses, and finally, don't count on bonuses. If your contract says that the bonus has some discretionary basis, don't budget based on your bonus, budget based on your base salary. And if you get the bonus, just consider it gravy. And remember that reimbursement, unfortunately, probably isn't going to go up over the next several years. So don't spend like you're going to be making a lot more money in 5 years when you're busier. And then finally, remember how to protect your assets with a trust and with insurance. And the last thing I'll tell you is choose to be happy. I think that there are some unhappy physicians in medicine, and I think that being happy takes effort on all of our parts.
Thank you, Matthew. And thank you all of our speakers. I mean, this was excellent, and I think this will help our future colleagues, I think, a lot. And what I'll will do is now we can discuss questions in the Q&A box, and I'll be honest, there are none. Maybe you already answered them, but there was a question Matthew already picked up on regarding, non-compete, and can you get out of it? So is it enforceable or not? Who would provide a little more information? I think Jordan also pointed that topic out, and that's usually in every contract probably you read, even if you go in academic medicine nowadays, you're not free from that topic.
As you'll recall, there was a recent proposal that non-competes would not be enforceable. That was struck down by a Texas court. It may come back up, but at this point, non-competes are enforceable. The precedent in most states is about 5 miles. But some of these groups really will spend a lot of money, and I've seen it where they spend quite a bit of money because, again, you've got a group of, maybe an equity capital group, and they've got 150 physicians. They've got a lot more resources to sue you and file an injunction and keep you from working.
Yeah, that's very interesting. Because I know here I'm in California, which is obviously a bubble compared to the rest of the country. We have a lot of protections against those things. But it's interesting, Dr. Holland. I didn't think that they actually try to enforce those. I know that they are on contracts, but my understanding was that they generally are like a paper tiger. I'm just surprised to hear that they actually, in some areas, actually go after the doctors for that. So that's actually great information for our trainees, so they can really think smart about that. Because I didn't think they actually bothered. So that's pretty interesting for me to hear.
Yeah, I
Yeah,
think I would say the same with Jordan. We have a loose non-compete, but they're not chasing someone who doesn't want to be here, and to go through the courts and have to try. They really usually, if you want to leave, that's fine, and work next door, they're fine with it. They're not going to, but it's on paper, definitely on paper.
Yeah, one aspect, what I've seen, it also depends what type of specialty you are. So if you're the only specialist in the state and you go across the road, that maybe look different than if you are a specialist who doesn't really have a practice or is a hospitalist and could be easier replaced and doesn't carry on a reputation to someone else. Another point what has been brought up, what I have seen is, again, it's the threat. And again, that's your nerves, because they're going to say, well, look at your pockets and our pockets and which one are deeper. So go and give it a try. Again, if that's going to materialize in a legal event or not. But again, that's also something you might hear. I also have seen that you can get out of non-compete, again, if you approach it in a certain collegial way and give reasons and not take things to the personal level. But again, that's not a guarantee, right? You may have partners who just say this is a business marriage, and they're going to go like this about it. So those are my few cents, and I've seen it. We have it in the new academic contracts too. I hear it more and more. Let's see, there are a few more questions now in the Q&A box. So question and answer box, feel free, write it in there. And one is a very important question, is that it always comes